Goda, Secretary NNF Karnataka chapter. It's my privilege to welcome all of you. A big warm welcome for all the participants, all the 200 plus participants who have logged in for today's session. And I would like to introduce our speakers for today's session. Dr. Rahul KADAM is a consultant neonatologist from Yashoda Hospital, Hyderabad. On behalf of NNF Karnataka chapter, the office bearers, and the entire NNF Karnataka members, we would like to give a warm welcome to you. Welcome, Dr. Rahul.
Thank you, Prashant.
Yeah, and he'll be talking on ventilatory graphics. Followed by his session, we have a well-renowned speaker from Hyderabad, Dr. SATISH GANTA. So he is a director and is a chief consultant neonatologist of Little Star Children Hospital, Hyderabad. We would like to welcome Dr. Satish Ganta sir as well on behalf of NNF Karnataka, office bearers, and the entire members of NNF Karnataka. A warm welcome to you, sir. So today's session will be moderated by our beloved Dr. Prakash Vemkal sir. It's indeed a pleasure to invite him as a moderator as well. He's the medical director and chief neonatologist and head of the Department of Neonatology and Pediatrics, Rainbow Children Hospital, Bangalore. Dr. Prakash sir, welcome on behalf of NNF Karnataka sir. So I request Dr. Rahul to start the session and over to you, Dr. Rahul.
Good evening all. Good evening all. Prashant, I'm audible and visible?
Yes. Kindly speak little louder and
yes.
Go with a moderate pace. Don't go too fast.
Okay, fine. Okay. So very good evening one and all. At the outset, let me thank NNF Karnataka team for giving me this opportunity. And I would like to congratulate them for carrying out this webinar series very methodically. So coming to the topic which is allotted to me, that's a ventilator graphics. Personally, I feel this topic can be better discussed at bedside or at workstations in small groups. However, I'll try and keep it interesting and I'll try and not make it boring monologue. So why we need graphics? So we need graphics to monitor the function of the ventilator, to evaluate the patient's response to the ventilator, to help us to adjust the ventilatory settings, and for early detection of possible adverse effects of mechanical ventilation, and to minimize the risk of ventilator-induced complications or any ventilator malfunctioning. So we are going to divide the presentation in three forms, that is normal waveforms. Then we'll see how graphics will help us to identify the mode of ventilation, and then we'll discuss how graphics can help us to identify and quantify the problem, to know the progression of disease, response to the drugs, and how to adjust ventilator settings with the help of graphics. So let us begin. So let's begin with the basics. So we all know there are two types of waveforms, scalars and loops. So scalars are the one where we have a pressure, volume, or flow on a y-axis, and we have a time on x-axis. So this timeline is nothing but a baseline where your pressure, flow, or volume will be at 0 level. Coming to the loops, we have two variables. So they'll be either on x and y-axis respectively. So it can be a pressure volume loop or a flow volume loop, and there is no time variable here. Why it is called as a loop? Because if you see here, the start and the end of expression, they coincide at one point. That's why it is called as a loop. So now just look at some basic sets of scalars. So scalars, they can be a square, there can be ascending or descending ramp, it can be a sine waveform, or it can be a decay waveform. So where do we get a square waveform? So whenever a set parameter is a constant, we get a square waveform. So it's obviously a pressure waveform in a pressure control mode or a pressure mode, or it is going to be a flow waveform in a volume mode. So where we are going to get a ramp waveform? Ramp waveform we get wherever the parameter is a variable. So it is going to be a pressure waveform in a volume mode or a flow waveform in a pressure mode. So this variable is going to change with lung characteristics, and the ramp waveform, it can be ascending ramp as a pressure waveform in a volume mode, or it can be a descending ramp as a flow waveform in a pressure mode. And sine waveform, we are going to get it in a spontaneous unsupported breathing. So there are three basic phase variables. The trigger is the one which causes breath to begin. Limit is the one which regulates the gas flow during the breath, and cycle is the one which causes breath to the end. So it can be a flow or a pressure trigger in assisted breath. It can be a time trigger in a controlled breath. Whereas it has to be a flow limit in a volume control mode, and it has to be a pressure limit in a pressure control mode. Whereas a cycle variable can be a volume in a volume control mode, can be a time in a pressure control mode, and a flow in a pressure support mode. Now just look at the pressure waveform. So here you're going to have a pressure on y-axis and time on x-axis. So in pressure mode, there will be a rapid and linear rise in the pressure to peak inspiratory pressure during inspiration, and then the pressure is going to remain at the same level throughout the inspiration, from where the expiration is going to begin as an exponential decay, and then it is going to come to the baseline. So this is how the pressure waveform will look in a pressure mode. So it's a square waveform with exponential decay during expiration. So now just look at the pressure waveform here in a pressure mode. As you can see here, the waveform is not starting at the baseline. So you have a peep added here. So whenever there is a peep added, you will have a higher baseline. And if you look at the second breath, there is a negative deflection before the start. So what does it mean? This is a patient triggered breath. Now coming to the volume mode, how the pressure waveform will appear. So there will be a rapid rise in a pressure till the break point, and this pressure is called as a airway resistance pressure. From here, there will be a ascending ramp to reach the peak inspiratory pressure. From there, again, pressure will drop a bit to a plateau pressure, and it will remain at the same level throughout the inspiration. And then again, there will be exponential decay during expiration. And at the end of expiration, the pressure will be at the peak level. The difference between the plateau pressure and peak is called as the alveolar compliance pressure. Now, if you look at here at a pressure waveform, the area under curve, as we know, is called as a mean airway pressure, and that is a direct correlate of oxygenation. So if you want to increase a map, you can try one or more of the following things if they are feasible based on the patient's condition. So what you can do, you can increase the flow to overcome the airway resistance. You can increase the peak pressure. You can increase the inspiratory time. You can increase the PEEP, or you can increase the rate. So that's about the pressure waveform. Now coming to the volume waveform, you have a volume on y-axis and time on x-axis. In a pressure mode, there will be a exponential rise of a volume during inspiration to inspiratory tidal volume, and from there you will have an exponential decay of a volume during expiration to the baseline. So if you look at the volume waveform in a volume control mode, you can see there will be a inspiratory hold or a plateau during inspiration. So that is the difference between the volume waveform in a pressure mode and in a volume control mode. Now look at the flow waveform. So here you have a flow on y-axis and time on x-axis. So during inspiration, you will have a rapid increase in a linear increase in a flow to peak inspiratory flow, and there will be a decay to the baseline, that is a zero flow, from where the expiration will start, and there will be a rapid decrease in the flow to peak expiratory flow, and then there will be exponential return to the baseline, that is a zero flow. So if you can see here, in a flow waveform, inspiration will be above the baseline and expiration will be above the below the baseline, whereas in a pressure and a volume waveform, you have both inspiration and expiration above the baseline. Now let us have a look at flow waveform in the volume control mode. So as I said earlier, flow is a set parameter in a volume control mode. So you are going to get a square waveform, square flow waveform in a volume control mode, and you can see an inspiratory pause or a zero flow state in a volume control mode. Now, we just saw this is how a flow waveform will look in a pressure control mode. So now look here, what's happening. If you can see here, the inspiration, I mean the flow during the inspiration is not coming to the baseline before the ventilation cycles into the expiration. So this kind of flow waveform you will see in a pressure support mode, and this is called as an inspiratory cycle of or expiratory trigger sensitivity. What does I mean by that? Inspiration ends when the ventilator detects the inspiratory flow has dropped to a specific flow value. So this is expiratory trigger sensitivity in a pressure support ventilation. And usually the set expiratory trigger sensitivity is between 25 to 30% of the total peak inspiratory flow. Now let us look at the loops. So first is a pressure volume loop where we are going to have a pressure on x-axis and volume on y-axis, and the central line, it represents the compliance at a zero flow state. When there is no flow, this represents the compliance of the lung. So this is how a PV loop is going to look into volume mode, almost oval in shape. The inspiration followed by expiration, and that is what we mean by hysteresis. What does I mean by that? There is always a lag. Inspiration and expiration, they don't coincide. So now, if you see the topmost part of the PV loop is represents a dynamic compliance, that is delta V by delta P. Now, if you see this line area represents the flow resistance during expiration, whereas the plain blue area represents the flow resistance during inspiration. And the sum of both, that is inspiratory and expiratory resistance, it represents the resistive work of breathing. Whereas this triangular part represents the elastic work of breathing. Remember, during normal expiration, there is no work done. So this is how the basics of PV loop. So if you look at the PV loop in a pressure mode, it's almost square in shape. And why it is so? Because you have a constant pressure applied during the inspiration. That is the peak inspiratory pressure. That's why it is a square in shape in a pressure mode. Now let us look at PV loops, how they look in a spontaneous, assisted, and controlled breath. So in a spontaneous breath, it will be clockwise. So first inspiration followed by expiration. And if you see here, the inspiration starts at a zero pressure, and then there is a negative pressure, and then expiration coming to the zero. Whenever you have a baby on a CPAP, this is how your PV loop will appear. So it is going to start at the set PEEP level. Now coming to the control breath. So in a control breath, pressure volume loop is going to be anti-clockwise. Inspiration followed by expiration. And again, you see here, it starts at zero. And if you have a PEEP set, it is going to start at the set PEEP level and not at the zero. Now coming to the assisted breath, in assisted breath, the PV loop will start as in a spontaneous breath as a clockwise deflection first, and from there the ventilator will take over and will deliver a mandatory breath. So it will be clockwise and then counterclockwise. So now just look at the flow volume loop. Here, remember, in a flow volume loop, you have a flow on y-axis, whereas a volume on x-axis. The inspiration will be above the baseline and the expiration will be below the baseline. Now, if you see during inspiration, there will be rapid rise in a flow to peak inspiratory flow rate. Then it will come to the baseline, and during expiration, there will be rapid decrease in a flow to peak expiratory flow rate, and then there will be a progressive return to the baseline. That is a functional residual capacity. Now, the shape of inspiratory portion of a flow volume loop, it will resemble the flow waveform. So what does I mean by in a volume mode, the inspiratory portion will be square in shape, whereas in a pressure mode, the inspiratory portion will be descending ramp shape. Whereas in a spontaneously breathing baby, it will be circular in shape. So here we have finished the basics of waveform. So just to summarize, scalars and loops, three scalars, pressure, volume, and flow, and two loops, PV loop and FV loop. Now let's see how we can use the graphics to identify the mode of ventilation. So when you look for the mode of ventilation, you should ask two questions when you look at the graphics, whether it is a pressure or a volume mode. And the second question should be whether it is a controlled or supported breath. Now, just look at the first graphics. Now you can see here, this is pressure, flow, and volume waveform. So you can see flow waveform is a square in shape. So what does it mean? The flow is a set parameter. And if you look at the pressure waveform is a ascending ramp. What does it mean? Pressure waveform is a variable parameter. So what you can make out from this, that it is a volume mode, as flow is a set parameter. Now the next question is a controlled or supported breath. So if you come to the volume waveform, you can see there is a mandatory inspiratory port. So this is a volume control mode. Now look at this diagram. So now you can see here, pressure waveform is a square in shape, whereas a flow is a descending ramp. So it's very clear that pressure is a set parameter. So this has to be pressure mode. Now you compare the first graph with the second graph. So what is happening in the first graph, you can see here, the flow waveform is reaching the baseline. There is a pause and then the expression starts. So what does it mean? This is a flow cycle pressure control breath. Whereas if you look at the second waveform, look carefully at the flow waveform, you see the inspiration is cycling into the expiration before the flow reaches the baseline. So what does I mean by there is an expiratory trigger sensitivity on, and this is a pressure support mode. Now let us look here. So again, two questions. Look at the pressure waveform. Pressure waveform is a square. So you have a set peak or a plateau. So by default, it's a pressure mode. Then look at the flow waveform. You can see there is an inspiratory cycle off or expiratory trigger sensitivity set. So this is a pressure support breath. You can look at the volume waveform. It appears as in a pressure mode. And then again, you have a look at the pressure waveform. You have a set PEEP level. So this is pressure support ventilation plus CPAP. Now let us look at this waveform. Again, pressure, flow, and volume. Now if you look at the flow waveform, there is a set flow, whereas a pressure waveform is a ascending ramp. And if you see the volume waveform, there is a inspiratory port. So this is volume control. Again, you see at the pressure waveform, you have a set PEEP level. So this is volume control plus CPAP. Now look at this waveform. Again, you have a flow, pressure, and volume. Now pressure waveform is square shape. So you have a this is nothing but a pressure mode. So one thing, first question to your first answer is it is pressure mode. Now the second question is whether it is a controlled or supported breath. Now if you look at the first breath, you can see there is a triggering. So this is a patient triggering. Plus you can see the flow waveform is reaching the baseline, and from where the expression is starting. So this is nothing but patient triggered time cycle pressure control breath. So this is a mandatory breath. Now you look at the second breath, look at the flow waveform, expiratory trigger sensitivity is on. So there is a pressure support as well. And then you look at the pressure waveform, you have a set PEEP level. So this is nothing but SIMV PSC path. So this is how we can make out the mode of ventilation by just looking at the graphics. Now, look at this slide. Actually, when yesterday Dinakar sir called me and he told me I should speak something about volume guarantee in graphics, and this is the only relevant site which I could find, because there won't be any difference in the graphics when you evaluate any baby on a conventional ventilation. You need to evaluate graphics in the same way. Now just look at this waveform. So what, again, you have a constant pressure, or not constant, say square waveform. So you have a pressure mode. And if you look at the flow waveform, inspiration followed by expiration without any pause. So this is nothing but time cycle pressure limited ventilation. Now look carefully at this waveform. There are two set parameters. So one is a pressure limit or a pressure max, and second is a target tidal volume. So though it is a time cycle pressure limited ventilation, you have a Pmax set and you have a set target tidal volume. So this is nothing but a volume guarantee ventilation. So what I mean by a volume guarantee ventilation, here the ventilator will deliver PIP based on the exhale tidal volume of a previous breath, so that the desired tidal volume will be delivered in the next breath. So what does I mean by, just look at here the first breath, that is A breath. So you can see the target tidal volume is achieved with the working P. Now look at the next breath. See, the target tidal volume is not achieved with the working breath. So what ventilator does, it increases the PIP within a permissible limit. You can see that it has not crossed the P max within a permissible limit to get a desired tidal volume. Now, what happens in breath D, you can see this increased PIP has resulted into increased delivery of tidal volume. So what ventilator does automatically, in the next breath, the pressure will be, or PIP will be reduced to get a desired tidal volume. So this is how the volume guarantee ventilation works. So even if the lung mechanics changes, say for example, there's a change in compliance or a resistance, or if there's a change in the respiratory effort of a baby, ventilator will make it sure that it will give appropriate PIP. That means it won't cross the Pmax or a set pressure limit. Now, coming to the third and the most important part of our presentation, that is how graphics are going to help us to identify and quantify the problems, how they are going to help us to know the disease progression and response to the drugs, and how we can adjust the ventilator settings based on the graphics. So the first problem which we can identify is increased airway resistance, and it can be both expiratory and inspiratory. Expiratory is more common, and the common causes of bronchospasm, secretions, or a damp expiratory filter. Whereas increased inspiratory resistance is because of ET tube related causes. It can be a blocked or a kinked tube, or it can be a small ET tube. So how we are going to identify it on the graphics? So if you see here, the increased airway resistance, and this is a normal resistance. In increased airway resistance, PIP, peak inspiratory pressure, will be elevated, whereas the difference between PIP and the plateau pressure will be increased. What I mean by airway resistance pressure will be increased, and as there is no problem with the compliance, the plateau pressure will be normal. So this resistance will appear in a pressure waveform. In volume waveform, expiratory part of the curve will take longer to reach the baseline, whereas in flow waveform, expiratory portion will take longer to reach the baseline. There will be prolonged expiratory time, as well as there will be reduced peak expiratory flow. So this is how the increased resistance will appear on scalars. Now coming to the PV loop, this is how a normal PV loop will look. When there is an increased airway resistance, PV loop will bulge. So whenever there is an increase in an inspiratory resistance, it will bulge to the right side. Whenever there is an increase in a expiratory resistance, it will bulge to the left side. Now on flow volume loop, the increase during increased resistance, you are going to see there will be reduced peak expiratory flow rate and the expiratory portion will be scoped out. So this is how the increased airway resistance will appear on scalars and loops. And how you're going to fix it, I'm not going to go into details of it. You just have to identify the cause, which we discussed earlier, and you need to correct the cause. Now the ventilator graphics will help us to know the response to drugs as well. So this is, as showed earlier, this is a flow waveform which will appear in a bronchospasm. You have prolonged expiratory time and the reduced peak expiratory flow rate. After giving bronchodilator, you will see there will be improvement in the peak expiratory flow rate and the expiratory time will be shorter. Similarly, on flow volume loop in bronchospasm, you're going to see reduced PFR and scooped out pattern. After giving bronchodilator, you can see there is a rapid rise in a peak expiratory flow rate and the waveform is much more flatter or linear. Now, the second problem which we can identify is a reduced compliance, and how it is going to look on a pressure waveform. Obviously, the peak inspiratory pressure will be elevated. As it is a problem with the compliance, plateau pressure will also be elevated. Whereas it is not a problem with the resistance, the difference between PIP and plateau pressure, that is airway resistance pressure, will remain same. Now, on flow waveform, you will see there will be increased peak expiratory flow rate and shortened expiratory time. How a decreased compliance appears on a PV loop. So we all know the PV loop will become flatter or it will shift to the right. And if you measure this angle, in cases of newborns with RDS, this angle can be less than 40 degrees. So that is reduced compliance. Now, graphics can help us to know about the disease progression and response to drugs as well. Now let us look at the PV loop in a pressure mode where we have a set PEEP which is going to deliver a particular amount of a tidal volume. So in conditions with reduced compliance, say RDS, what is going to happen? The PV loop is going to shift to the right side, and with the same PEEP, you are going to get less tidal volume. So in the same way, when you give a surfactant, what is going to happen? Your PV loop is going to shift to the left, and you're going to get the more tidal volume at the same PEEP. So you can monitor disease progression and response to drugs both. Coming to the volume mode, PV loop in volume mode, you have a preset tidal volume and then the pressure varies to get that tidal volume. So in RDS, the loop is going to shift to the right and you're going to require more pressure to get same tidal volume. Whereas once you give a surfactant to this baby, you can see that the PV loop will move to the left side and you require less pressure to get same tidal volume. Now, the next problem which can be identified and quantified with the help of graphics is auto PEEP. Auto PEEP is a dynamic entity and it won't be present in all the breaths. So this is the average pressure by trapped gas in a different lung units. This is a potential cause of hyperinflation and it can lead to barotrauma, worsening oxygenation or hemodynamic compromise. So what are the usual causes? So it can be with intrinsic expiratory flow limitation, which is rare in newborns, whereas it can be without intrinsic expiratory flow limitation, which is more common in newborns, and it includes rapid respiratory rates, higher tidal volumes, short expiratory time, or a small size AT2. Now, how it is going to appear on the graphics? So this is a pressure waveform, what we see regularly, and if you apply an expiratory hold in a pressure waveform, you see that expiratory waveform rises above the baseline, and that's called as a auto PEEP. And acceptable auto PEEP is less than 5 centimeters of water. Now, in the volume waveform, what you see is the expiratory portion does not return to the baseline, and that is your air trapping or auto PEEP. Whereas this is a normal flow waveform where you can see like inspiration followed by expiration. Whenever there's an auto PEEP during expiration, it won't come to the baseline. It won't reach to the baseline. So that's called as a air trapping or auto PEEP. Now this is a PV loop, normal PV loop. How your auto PIP is going to appear in a PV loop. During expiration, so expiratory portion of the loop is not going to return to the baseline. So this is the auto PIP and you can measure it as well. So similarly, in a flow volume loop, the expiratory portion is not going to return to the baseline, and this is auto PIP, which you can measure it here. Now, how you are going to treat auto PIP? So you can either change the ventilatory settings, that is, you can increase the expiratory time, you can decrease respiratory rate, or you can decrease the tidal volume. You can reduce the ventilatory demand by reducing anxiety, pain, or fever, or giving sedatives. You can reduce flow resistance by putting a large bore tube, or you can counterbalance any expiratory flow limitation by external PIP. So now the next problem which we can identify with graphics is air leak. So it can be expiratory leak as ET tube cuff leak, chest tube leak, or BP fistula, or it can be inspiratory leak. It can be because of loose connections, ventilator malfunction, or a faulty flow sensor. So how it is going to identify, how we are going to identify it on graphics. In the volume waveform, you'll see that during expiration, the expiratory portion does not return to the baseline. So that is your air leak. Now, see at this graphics, you can see in a volume waveform, you can see there is a air leak. So whenever there's an air leak, in a pressure waveform, there will be a reduced peak inspiratory pressure, and in a flow waveform, there will be decreased peak expiratory flow rate. So this is how air leak will appear on scalars. Whereas this is a normal PV loop, and you can see here the expiratory portion does not reach the baseline, and that is your air leak. Similarly, in a flow volume loop, your expiratory portion is not going to reach the baseline, and that is your air leak. Now, how we are going to fix it? You just have to treat the causes what we discussed earlier. And important thing, like whenever you ventilate a baby, beforehand you do a leak test and make sure that all corrections are tight. Now, another problem which we can identify on a PV loop is over distension. So this is a normal PV loop. So when you increase a pressure beyond a limit, you can see beaking. Over distension you can see as a beaking, and there will be a little or no change in the tidal volume with rise in a pressure. Now you can measure it. How you can measure it? You can measure a compliance during last 20% of the breath, that is C20, and then you can measure a dynamic compliance, and the ratio of C20 by C dynamic or C dynamic compliance. If it is less than 0.8, few people tell less than 1, it indicates it is an over distension. Now, if there are secretions, airway secretions or a fluid in the circuit, you can make it on a flow volume loop. You'll see that expiratory portion will be sedated or irregular. Now, what do we mean by ventilator patient synchrony? So, ventilator should start inspiration at the time of onset of patient's inspiration. That is trigger synchrony. The flow provided by ventilator should meet the flow demand of the patient. That is flow synchrony. And ventilator inspiratory time should match with the patient's inspiratory time. That is a cycle synchrony. So whenever any of these three parameters are not in sync, it is called as a ventilator patient asynchrony. And it can be either a trigger, flow, or a cycle asynchrony. And graphics will help us to identify the ventilator patient asynchrony and to rectify it. So ineffective triggering is a failure of patient's inspiratory effort to initiate a ventilator breath, and the important cause is improper trigger sensitivity. Now, if you see here, this is a pressure support ventilation, and if you look at this particular breath, you can see like there's a patient triggering. You can make out by a negative deflection, but if you see at the flow waveform, there is very little rise in the flow, and there is no initiation of the breath. So that is ineffective triggering. Now, auto triggering is what? Ventilator delivers an assisted breath that was not initiated by the patient, and the usual causes are fluid or leaks in the circuit. Now, how you make out? You can see here in the first breath, it is a negative deflection. So this is a normal breath, patient triggered normal breath. And if you look at the next breath, because of a leak or fluid in the circuit, you see the pressure has dropped below the PEEP level, and that has triggered the breath, and that is a auto trigger. Now, double triggering is what? Here, patient's inspiration continues after the ventilator inspiration, and it triggers another breath immediately after the inspiration. This is called as a breath stacking as well, and usually the short inspiratory time is the cause. So you see here, this is a graphics from a patient with asthma. Because of short inspiratory time to avoid auto PEEP, you can see there is a double stacking or double triggering. And once you adjust the I time and give bronchodilators to this patient, you see there is no double triggering. So this is how graphics will help you. Now, delayed triggering, it is an inherent problem of all the ventilators. You can overcome with new modalities like NAVA, which we are not going to discuss here. And delayed triggering, you can make out by a negative deflection in a pressure waveform and change in the slope of a flow waveform. And this marked area represents the amount of delayed triggering. So more is the patient effort, more delayed will be the triggering. Again, delayed triggering can be because of inadequate trigger sensitivity, which you can make out on a pressure volume loop. If you can see here, the patient's inspiratory efforts, they reduce the pressure well below the PEEP and triggers the breath. So there is a lot of work of breathing. And once you adjust the trigger sensitivity, you can see the minimal patient efforts are required to initiate the breath. Now, flow asynchrony can be because of many causes such as air hunger or low settings on the ventilator. Now, if you look at this scalars, in a flow scalar, you can see there is an inspiratory pause or zero flow. That's called as zero flow state or flow starvation. And on a pressure waveform, you will see there will be dipping of the inspiratory portion. Whereas flow starvation on a PV loop, you'll see dipping or cusping of the inspiratory portion. Similarly, on a flow volume loop, you will see dipping of the inspiratory portion. So, how you can fix it? You need to treat the underlying causes. You can treat the fever. You can increase the tidal volume if possible. You can increase the flow rate if possible. You can change to pressure control mode from a volume mode if possible, and you can sedate the patient. Now, coming to the cycling asynchrony, it can be delayed cycling where ventilatory inspiratory time is more than patient's inspiratory time. So, ventilator continues inspiration when actually the expiration has started. So, in a pressure support mode, if you put expiratory trigger sensitivity very low, it will lead to delayed cycling and it will lead to exhalation spike during breath. Patient breaths actively and it leads to increased work of breathing. So how you can fix delayed cycling? You can decrease the inspiratory time, you can decrease the tidal volume, and you can increase expiratory trigger sensitivity in a pressure support ventilation. Now, if you see here, there is a expiratory trigger sensitivity is very low and it leads to exhalation spike. Once you increase the expiratory trigger sensitivity, there is no spike. So this is how graphics will help you to correct the asynchrony. Now, premature cycling is where ventilatory inspiratory time is less than patient's inspiratory time. And what happens here, you can see here, the patient's inspiratory efforts, they'll continue into expiratory phase of ventilator breath. So, in a pressure support ventilation, if you put expiratory trigger sensitivity very high, it will lead to premature cycling and the tidal volume delivered will be low. Then how you are going to fix it? You can increase the inspiratory time, you can increase tidal volume if possible, and you can decrease the expiratory trigger sensitivity in a pressure support mode. Now, when we speak about ventilator graphics, we should speak about one parameter on the or one setting in the ventilator. That's a rise time. This is nothing but amount of time to reach the desired airway pressure or a peak flow rate. You can see this is a rise time in a pressure mode. So it helps to assess whether ventilator needs are met in a pressure support ventilation, and it becomes a percentage of breath cycle in a SIMB mode. Now, if your rise time is too fast, what is it is going to cause? It is going to cause a pressure spike during the inspiratory portion of the waveform. And what you can do to rectify it, you can increase the rise time so that the flow valve will open slowly and the overshoot will be corrected. Now, if your rise time is too slow, what will happen? You can see the slanted pressure waveform and the less tidal volume will be delivered. In that condition, what you can do, you can decrease the rise time so that the flow valve opens faster and tidal volume will improve. Now, let us look at briefly about the abnormalities of a flow waveform. In controlled breath, inspiratory flow pattern is affected by I time. What does I mean by this? If you look at this flow waveform, what is happening here? Flow is not reaching to the baseline before expression starts. So in a controlled breath, this flow waveform indicates short I time. Now look at the second waveform. Second flow waveform, the flow waveform reaches the baseline and from there the expression has started. So this is a normal I time. Whereas in a third waveform, if you look, the flow has reached the baseline before preset I time and there is a inspiratory pause. So in a controlled breath, this is prolonged I time. So now how we can set a proper I time with the help of flow waveform. Let us take an example of a baby which you have put on pressure control mode with a peak of 15. Your desired tidal volume is at 20. And now if you look at the volume waveform of this baby, the delivered volume is 15 only. So if you see this, what you will do first, you will try and increase in pressure to get increase in the tidal volume. But you will do so only when if you're not looked at the flow waveform of this baby. Now let us look at how the flow waveform of this baby is. So this is how the flow waveform of this baby is. So what is happening? The flow has not reached baseline and the expression has started. What does it mean in a controlled breath? There is a short I time and this short I time has led to the loss of volume in this baby. So once you set appropriate I time in this baby, you will get a good tidal volume. So without increasing the pressure, just by adjusting I time, you have improved a tidal volume of this baby. Now just look at the next slide. This is a flow waveform in a baby with RDS, and what you see that there is a fixed I time. Now, what happens in early stages of RDS? You have short time constants and lungs are stiff. So this fixed I times may help for you to get adequate maps and oxygenation. But once the lungs become compliant, particularly in a baby who is breathing faster, this fixed I time will inadvertently become prolonged I time and it will shorten the expiratory time and it will lead to auto PEEP. So how you can rectify it? You can reduce the I time or you can turn on the expiratory trigger sensitivity. So this is how the flow waveforms will help you to adjust the I times in different conditions. Now let us look at how we can optimize PEEP with help of PV loops. Now just look at here, we know that residual volume is the amount of gas into the lungs at the end of maximum expiration. Critical opening pressure is the pressure which requires to overcome the surface tension and to open up the alveoli, and obviously it will be more than a residual volume. We know that FRC is amount of gas into the lungs at the end of tidal or passive expiration. Whereas total lung capacity is the total amount of gas into the lungs with the deepest possible breath. Now, if you look at the pressure volume relationship curve, there are 2 points. One is a lower inflection point. It corresponds to the critical opening pressure. That's why it is a point of a alveolar opening. So below this point, most of the alveoli will be collapsed. Whereas another point is upper inflection point where most of the lungs unit will have a high possibility and rise in pressure beyond this limit will lead to the over distension. And the portion of a PV curve between these 2 points is the favorable portion of the curve. And what do we mean by optimum PEEP? Optimum PEEP is the one which keeps the most of the lung units in this favorable portion of the curve, so that most of the alveoli are open, you get higher tidal volume without any overdistension. So this is how your LIP and upper inflection point is going to look on a PV loop. And it is said that in ARDS lungs, you should set PIP just above the lower inflection point. Now, just look this pressure volume curve in one of the patients where we have set a PIP of a 5 and PIP of 18 with map of 13, and the tidal volume what we have got is around 8.7 and compliance is 0.67. Now we have tried to bring the loop of this lung units of this baby in a favorable position by reducing PIP to the 4 and PIP to the 17, and with same map you can see we have got higher tidal volume and good lung compliance. So this is how the PV loop can help us to optimize the PIP to get higher tidal volume without any change in the maps. So this is my last slide just to sensitize you how a trending of waveforms will help you to guide for weaning. So now look at this volume waveform where you have a mechanical breaths followed by a spontaneous breaths. And if you see here, the spontaneous breaths in between the mechanical breaths have an ineffective tidal volume. And if you look at the volume waveform of same baby at an interval, you can see the spontaneous breaths have a good tidal volume, and possibly this baby is ready to wean. So trending of waveforms can help you to decide about weaning of the babies. So my take homes will be ventilatory waveform analysis is an integral component in the management of any ventilated patient. You should develop a habit looking at the right waveform for the given mode of patient ventilation. Always, this is very important, always look at the inspiratory and expiratory components of flow time waveform, and don't hesitate to change the scale or spread of the waveform to aid in your interpretation. Finally, experience is a valuable thing. It enables us to recognize mistakes when we repeat them. So, experience the graphics. Thank you all.
Thank you, Dr. Rahul. Fantastic presentation and a very brief and very comprehensive and very clear presentation. Thank you very much for that. Now I request Dr. Satish sir. Dr. Satish sir.
Yeah. Can you hear me?
Yes, sir. Yes, sir. Yes, sir.
Yeah.
So you can start sharing if you can. If it's not working, I have the presentation and start doing.
No, I can. I think I can start now.
Yeah, yeah. Share screen.
Yeah. How just can you help me with that, Prashant?
Share screen. Share screen. First, you open the presentation, yeah. Sir.
Yeah, I opened the presentation.
Yeah. Now you open. Yeah. Now you press. Come to Zoom. Press. Yeah. Share screen.
I can't see the switch to gallery view. Is it that one?
Not gallery view, sir. Share screen is there. Share is there.
Share the content.
Share the content. Yeah.
Yeah. Photos, iCloud Drive, Dropbox.
Wherever you have kept the presentation.
Yeah, it's on my desktop only.
Yes, sir. Yes, sir. If you have opened it, the moment you press the share screen, you'll get it.
Oh, I'm not able to get it.
Yeah, I think something.
Can I just log out and come in again?
No. You can. I'll do one thing, sir. Presentation is ready.
Yeah, now can I get it? Did you get that?
Yeah. Can you see the presentation now, sir?
Yes.
Yeah, I have shared for you. You tell me, I'll change for you. Start the presentation.
No, I got that. No, I got that.
You got it? You want me to stop the sharing?
Yeah.
Yeah, you can share now, sir.
Yeah. Can I share now?
Yeah, yeah, please, 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 sir. Please, sir.
Share screen.
It's on, it's on.
Yeah, my share screen is on now. Can you see if whether my share? Can you see my?
No, 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 sir. No, sir. We cannot see your share screen yet.
Okay, fine. Okay, then how do we go forward?
No, I will start. I will share your presentation.
Yeah. Okay, so basically, yeah. Can you see me at least?
I can't see you, sir. Your video is off.
Okay.
Now
Can
I
I?
yeah.
You
If
can,
you
right?
tell like this, I'll keep changing the slide.
Yeah, I'll ask you. Can you share now? Yeah.
Okay, sir.
Yeah.
Sir,
Okay.
a warm welcome to you, sir.
Yeah. Thank you.
And Dr. Prakash, sir.
Yeah.
Yeah.
Hi, Satish.
Hi. Hi. Hello, sir. How are you?
Good, good. Welcome to this webinar. Looking forward to hear from you. Go ahead.
Yes, sir. Thank you very much for joining, sir. We welcome you on behalf of NNF Karnataka. And you have done your master degree from KMC Manipal.
Yes.
And you part of you belong to us. Thank you
I
very
am
much.
I am a Kannadiga.
Okay, sir. Thank you very much for accepting the offer
Yes.
and being a speaker. We have done so many publications, and we have done your fellowship from Australia, and you have been quite popular all over India. And we are all looking forward for your talk, sir. Over to you, Dr. Satish, sir.
Yeah. At the outset, I'd like to thank Dr. Prashant, Dinakar, and the whole NNF team. You know, it was a beautiful gesture on their part to ask me to come and do this session. It's a pleasure. Thank you very much again. Thank you. So without much of a late, let's go on to this presentation. Next slide, please. Yeah. So the high frequency ventilation, basically the first and foremost thing that we would like to know, the most important thing is basically it uses supraphysiological respiratory rates that greatly exceed the normal breathing rates with minimal tidal volumes. That's the whole point. So you have higher respiratory rates, but with minimal tidal volumes. That's how, that's the simplest definition that you could do it for high frequency. Next slide, please. So the basic concept for adequate gas exchange in conventional ventilation, we all think is the tidal volume. It should exceed the volume of the dead space or the conducting airways. So that's the usual thing that you see in conventional ventilation. So the application of this basic principle of respiratory physiology in the conventional mechanical ventilation means that the tidal volume, as I've said, is higher than the alveolar dead space, which can be described as F is, so VA is equal to VT minus VD. So VA is the alveolar volume, VT is the tidal volume, and VD is the dead space. So obviously here in the conventional ventilation, so the tidal volumes are certainly higher than the dead space volume. But in the high frequency ventilation, it relies on a different principle where the tidal volumes are much, much lower than the anatomical dead space. That is only 1 to 3 ml per kilos. Whereas conventionally we say anywhere around 4, maybe to 5 ml per kilos. So, but this is at a much, much higher frequency. Next slide, please. Next slide, please. Yes. So the high frequency, so basically these are the three, this is the basic rationale in a high frequency. So number one, it achieves a good gas exchange with tidal volumes that may be lesser than or equal to the anatomical dead space, as I just said. So the big use is it reduces the volutrauma. The second thing is it facilitates a gas exchange at lower peak parenchymal airway pressures than the conventional. So it reduces the risk of barotrauma. So these are the two things. It reduces the volutrauma and the barotrauma, and the breaths are delivered by a vibrating diaphragm that provides for both the inspiration as well as an active exhalation. That's the whole thing here. So there is a, usually it's positive inspiration, whereas the expiration is passive. But here in the HFO, there's an active exhalation happening. And this continuous distending pressure, when applied appropriately, it assists the recruitment, maintaining the optimal lung volume. Next slide, please. Yes. So these are the usual rates. If you see the three principal types, one you have the interrupter, which is not in vogue right now. But the other things are, you have a HF positive pressure ventilation at rates of 60 to 150 per minute. You have high frequency jet ventilation, rates of 240 to 660 per minute. And the volume of entering gas, that is, it's an operator control thing. And the next thing is your high frequency oscillator ventilation. That is between rates of 300 to 900 per minute. The other thing, that's the interrupter, actually, which is not in vogue. So these are the three usual things. And in this presentation, we will be most probably talking about the oscillatory ventilation only. Yeah, and that's what I said. Because the high frequency positive pressure, again, the tidal volume is more than the dead space in both that as well as the jet ventilation. Only in the oscillator, where the rates are higher, the tidal volumes are much lesser than the dead space. So the advantage, that's what we've just discussed. And because of this, the barotrauma is less, and the ventilator-induced lung injury is also much, much lesser. That's the theory. So in the type of oscillators, the next slide, please. You have two varieties. One is the hybrid variety. They are the newer varieties, which you're seeing a lot of them. The usual varieties that we see is the Fabian, the Draeger VN500, and the SLE, the 5000, as well as the 6000. Whereas the standalone models are the Sensor Medics 3100A and B. So these are the two differences. Whereas the hybrid one, you get a more sinusoidal pressure waveform. Whereas in Sensor Medics, it's more of a sinusoidal and more of a squarish type of a wave pattern. So these are, next slide, please. So these are the classification of the ventilator types that you see. And it's only in the first, it's Sensor Medics, Draeger, Fabian. Leone, not much you see here. And SLE, again, you see the other two is not to be seen here as well. Next slide, please. So this is something that I'd like to talk about. It's a schematic of the circuit for delivery of a high frequency. So here, what we need to see is, from the top, you have these quasi-sinusoidal flow oscillations generated by a diaphragm. It's applied from the airway opening right from the top. Okay, so you have, that's from the top. And if you see on the right side, you have the inspiratory flow or the bias flow. There you get fresh gas, which is humidified. And that is what goes inside the child. And that is, it flushes out the carbon dioxide, and the air that is through the outlet. Okay. So you have a mean airway pressure, which is regulated by two things here. One, there's adjustment to the bias flow. And at the same time, there is a resistance of the expiratory limb as well. So in practical terms, next slide, please. So in practical terms, what happens is HFO is basically a mixing device that rapidly blends the high oxygen and the low CO2 from the top with the gases in the alveoli. So the net transport occurs along the partial pressure gradient. The carbon dioxide is moving out of the lungs, and the oxygen is moving inwards to the alveolar and capillary interface. Next slide, please. So this is an interesting waveform of the high frequency pressure oscillations. So here you see the pressure and the time on the X and Y axis. You see that here. And in the center, what you see is the mean airway pressure. It's depicted around 30 centimeters of water, right? So that's the mean airway pressure. And what your oscillations does is, around the mean airway pressure, you have the oscillations equally on either side. That's your delta P. That's your amplitude. Okay. So these flow oscillations cause a symmetric oscillations. That's the delta P around the map. So both the inspiratory and the expiratory flows are actively driven by the oscillator diaphragm. Okay. So that's the thing. And basically, so if you see very, very crudely, if you want to talk about HFO, it's just like a CPAP, which just gives a distending pressure, a mean airway pressure. And on top of that, you have your oscillations, built-in oscillator or a shaker. That's more for the carbon dioxide elimination. Next slide, please. So in summary, Next slide, please. Yes. So the basic physiology here, it uses, the HFO uses a constant descending pressure. That's the map or the mean airway, with pressure variations oscillating around the map at very high rates. So this creates small tidal volumes, often which is less than the dead space. So in CMV, you see large pressure changes. You know, you have PIP and you have peak and expirator pressure. So the excursions are huge. So there's a physiological tidal volume and gas exchange. It depends on more of bulk convection, because the expired air is exchanged for the inspired gas. So here that's what happens. And there are large pressure and volume changes associated with CMV. And that's what we all feel is more the chance, the reason why we have more villi or, you know, barotrauma or volutrauma or ventilator-induced lung injury or CLD. So we feel that maybe with the high frequency, it's much, much lesser. So the HFO basically relies on alternative mechanism of gas exchange, which we'll certainly talk about now. There are multiple things, okay? Next slide, please. Yes. So as I've said, we've discussed about what the CMV does and what the HFO does, okay? So the main thing here, the biggest fascination, what I find in high frequency oscillation is, in the conventional, we always talk about everything is interdependent to each other, because whatever knob you change, there's going to be a difference in the other things as well. But here, when it comes to the oscillation, the ventilation or the carbon dioxide elimination to the oxygenation is completely, you know, independent of each other. The oxygenation is regulated by reversing the atelectasis and then finding the mean descending pressure that maintains this alveolar expansion, and the FiO2 obviously is set on that, right? Whereas the carbon dioxide elimination is relatively independent of the mean airway pressure, and basically this is regulated by the frequency and the delta P. That's the most important thing, right? Next slide, please. So what are the proposed mechanisms? There are lots of them you see in the textbooks as well, but let me try to simplify it, make it very, very simple. Okay. Next slide, please. So theories as to why the ventilation can still occur even when the tidal volumes are less than the dead space. These are the 5 theories. One is augmented diffusion. The second is your bulk axial flow. Third is your interregional gas mixing or the pendulum. And the fourth is your axial and radial augmented dispersion. That's the Taylor dispersion, and your convective dispersion as well. Okay, this is a very, very busy slide. This is what you see in your regular textbooks. I thought I'll make it a little bit more simple. So the next slide, please. So this is the turbulence that you see in the large airways. This is where the enhanced mixing happens. The next slide, please. This is quite important. The next slide. This is the summary of the gas exchange. This is the most important thing. The first thing, as you say, there's turbulence right at the top, okay? And this is your convection. So here, there's a direct ventilation of closer alveoli. The turbulent gas which comes in aerates these direct ventilation, aerates this alveoli here. And there's a direct ventilation happening to all the alveoli which are closer. The next mode is your convection along with your diffusion, So here, there's a turbulent flow as well as a radial mixing, which happens here. Along with this, you have an asymmetric inspiration as well as expiratory velocity profiles. Along with that, you have your velocity profile of inspiration as well as your velocity profile on the expiration as well. And the third thing along with this is your pendulum mechanism. So this summarizes both your convection as well as your diffusion. And the last is your diffusion, where you have your laminar flow and radial mixing and your collateral ventilation as well. Yeah, next slide, please. Yeah, when you talk in much more, next slide, please. So let's talk about bulk convection, okay? Let's talk about bulk convection. In this bulk convection, you know, the more gas is entrained into the alveoli by the by the vacuum left when oxygen is absorbed into the capillaries. The whole of the normal human ventilation can be described as bulk convection. The definition is the movement of group of molecules through a medium of other molecules. In short, this is tidal volume with the actual entry and exit of gas through the patient. In HFO, where the tidal volume is negligible, the bulk convection is represented by continual entrainment of fresh gas. As I've said, the oxygen is absorbed at the alveolus, and the decreased pressure generated by continual gas removal makes space for more gas. Next slide, please. The next is your pendulum. This is what, so here, basically, this is a strange German word. It describes the movement of gas from some alveoli into the other alveoli. So basically, in small, it's called exchange of gas between lung units, not from the ventilator into the lungs. It's between the lung units, right? So you have some alveoli which are absolutely nicely aerated and nicely opened up, no atelectasis, and then you have alveoli which are partially atelectated. So here what happens is the gas is exchanged between lung units which have different compliance and therefore different time constants. So this is one method. Okay, the next one, please. Next slide, please. Okay, so the next one is your Taylor dispersion. So here, the gas is exchanged between the central rapid jet of oxygenated gas and the relatively oxygen poor gas at the periphery of the airways. There's increase in the diffusivity of a substance which is subjected to shear force. So the jet of fresh oxygenated gas which is pushed down the center of the airway, and this jet then diffuses into the gas at the periphery of the bronchi, which certainly enriches it with oxygen. The next slide, please. The coaxial flow. So here what happens is the gas on the outside of the tube flows more slowly than the gas which is actually in the center, placed centrally inside the tube. Because of this, there may be a bidirectional flow of gas with the gas on the outside moving in the expiratory direction, even while the central gas moves in the inspiratory direction. This could be other way it could be sort of flowing. And the next is the augmented molecular diffusion. Next slide, please. So the violence of this oscillator imparts such force to the gas that molecules find themselves pushed to and fro with the substantially greater force, and the mechanical energy of the oscillator thus imparted. So there's an increase in the velocity, and this enhances the diffusion of gas through a gas-filled compartment. This is called the Brownian motion. So of all these 6 ways in which the gas exchange happens, certainly the most important thing is your bulk convection and your pendulum along with your Taylor dispersion. Next slide, please. So this is the usual ventilator that we are all used to. Yes, you have so many other models. So pretty much I've been using all varieties. But here is a SensorMedics model. And next slide, please. And this is again the graphics in the SensorMedics. Next slide, please. Yeah. So what are the indications? We'll talk about each and every vent. We'll talk about each and every sort of oscillator, at least the 3 or 4 common ones, so that we could see how we can set it up and see how we go. Okay. The common indications is the usual things. Pulmonary air leaks, when there is a early PI in a child who's premature, certainly we would prefer oscillation. If there's pneumothoraces or recurrent, certainly that's a indication. Again, a pneumomediastinum, bronchopleural fistula. And when there is respiratory failure on a conventional, that means you're trying conventional, you're not getting anywhere, you're having to use high pressures as a rescue therapy, certainly you could use this. Even in a child with a hypoplastic lung, like in diaphragmatic hernia, PPHN with meconium aspiration syndrome, or in a severe RDS as well, or in a pneumonia which is quite severe. You could always use it in a child who's having, NEC with quite a bad distended abdomen. So this certainly helps as well. Next slide, please. So what are the advantages? So as we discussed, it's certainly efficient mode of CO2 removal. That's very, very important. At the same time, the CO2 removal is very, very good with oscillator. It's safe. Why? Because you're using much lesser pressure. So there's more efficient removal of the CO2 without the excess pressure. At the same time, at any given lung volume, when we're using this high frequency, more than 10 hertz, ventilation can be adjusted relatively independent of the oxygenation. So once the lung volume is optimized, it can be maintained at a descending volume. Next slide, please. So applied correctly, so it promotes a focus on optimal lung volume and recruitment, as I've said, reducing the barotrauma and the volutrauma. It reduces the risk of both static as well as dynamic volutrauma with more compliant alveoli. It reduces the risk of static atelectatic trauma associated with poor compliant alveoli. And it prevents the propagation of lung injury by supporting adequate gas exchange with very small tidal volumes, up to 2 mils per kilo. It improves ventilation perfusion, at the same time decreases the dead space volume and maintains a good gas exchange with less lung injury. And it also improves the cardiac status. Next slide, please. So what are the disadvantages? Not many, I would say, but if you're using very high mean airway pressures, then what happens is the kind of pressure that you use is a lot, then obviously your venous return is impeded. And once your venous return is impeded, there is a pretty much significant cardiac dysfunction along with that compression. So these are the two things that you need to be careful about. Next slide, please. Next slide. Yes. So this is your basically this is the graph which I've said the basic how is the diaphragm and how is it positioned. So this is an electromagnetic coil-driven piston which pushes a flexible diaphragm which generates the oscillation in pressure. The gas pressure in the circuit is kept at a constant by a series of pressure regulators and valves, and the expression generally does not occur except by pressure release valve opening by the cuff leak. So this is very, very important. This is simple. What you have, as we've discussed before, you have the inspiratory limb and the expiratory limb. So you have the piston here, which generates the sort of the sinusoidal wave pattern. And around this mean airway pressure, this sinusoidal wave pattern amplitude goes in, and then that's what generates the oscillations. Next slide, please. So coming to the settings on the high frequency, this is quite important when you get to the basics as to how do you get on to the whole process. First, we should understand that each of these oscillations, all of them don't work the same way. The sensor medics, the Fabian, or the SLE 5000 or 6000, or for that matter, your Draeger VN 500. The way they work is different. So many a times they ask, sir, what is the usual pressures that you keep your child on in terms of, when you get this child on the oscillator? See, it is very, very different. What pressures you use, it depends on the child. It depends on the baby. And it depends on the machine you are using. So let us say you're using a delta P of 50 on a VN 500, or for that matter, your SLE 5000 or 6000, or even Fabian. It is very, very different to a sensor medics, very different. So I've hardly ever had to use a delta P of 50 or more than 40 or 45. That is the difference. The power of the machine is very, very different. So it's very, very important. It's like horses for courses. You need to know your machine well. You need to know yourself well. What are you comfortable with? What have you learned your oscillation on? So what is the important thing here is what oscillation you are used to and how is the child. It all depends that way. So having said that briefly, so let us go to what are the modes that we have. Okay. First thing is your bias flow. Go to the old slide, please. Previous slide. The first and foremost thing is your bias flow. It controls the flow rate of fresh humidified gas. And what's here is maximum is about 40 liters per minute. Usually we don't change this. Okay. The next one is your mean pressure adjust, or that is your MAP, your mean airway pressure. This is the one which controls the mean airway pressure. This is purely a pneumatic valve. Increasing the bias flow will certainly increase this mean airway pressure. So that also is important. So if you increase the bias flow, all of a sudden you notice that the MAP has suddenly increased. So because they are interrelated. as I said, because it's a pneumatic valve. The next thing that is important is your delta P or your power or your amplitude. This is basically the diaphragm excursion, how much the diaphragm is, moving. The nearest thing that you get to a tidal volume, it ranges anywhere between 0 to 100%. So this is important because we should know, we should understand this delta P is different in different, oscillators. The next thing is your inspiratory time. So the diaphragm excursion can be asymmetrical. It can spend more time in the inspiratory phase or the expiratory phase. What we want, it should be more physiological. So what is more physiological? Your inspiration, expiration. Our usual, physiology is 1:2. 1 part to and 2 parts to expiration. So what you see in your, how it's expressed in your HFO as a percentage, right? Then next. The next thing is your frequency. So frequency, this is the setting of frequency in the oscillator in hertz, and anywhere between 3 to 15 hertz. Now, the first thing that you go is your control of oxygenation. Remember in the earlier slides, I've said the beauty of oscillation is if you want more oxygenation, the only thing that you need to meddle with here is your MAP as well as your FiO2. That's it. So your MAP or your mean airway pressure, it controls the oxygenation. This is the main controlling variable of oxygenation. Typically, by setting a MAP, one can achieve maximum lung inflation and the alveolar surface area available for maximal gas exchange. So initially, so this is important here. So when you want to have the child on the oscillator, before you do that, you need to see what your existing pressures are on the conventional ventilation. Let us say your existing pressures are anywhere between 25/5 or let's say 25/6 with a mean airway, let's say 18. So what you need to do here is you choose a MAP around 2 or 3 higher than the mean airway in the conventional ventilation. That is important. Okay. And then you need to see how you recruit the lung. I will talk briefly only about recruitment because the next class certainly is it's one topic only about recruiting the lung. So here what we need to understand is, many a times I ask, many of the doctors or my PGs or my students keep asking me, yes sir, we've got the baby on the oscillator, child it's wiggling well. It's not important at all. It's not only important that you get a good wiggle, until where you get a wiggle. It's a complete thing. There are 4 things that you need to see. First, look at the baby, look at the monitor, look at the X-ray, and look at your investigations last. So that is extremely, extremely important. Okay. So you need to recruit the lung well. Without recruiting the lung, there is no point in just, okay, the rule says 2 to 3 centimeters above the MAP, just get this baby on the oscillator and then move away. No, that's not how it works. So when I say MAP of 2 to 3 above the conventional ventilation, what I'm just saying, it's just the initial point. That's all. So the initial point is you try to get onto the conventional, from conventional to the oscillation. But what is important is what is the ideal thing. So you need to recruit well. I think the next class we would cover that. But there are many, many things here. Again, as I said, you look at the baby. How is the oscillation? You should train your finger, inspiration. You should train your finger to see, is the wiggle good on both the sides? So it is not only the vision. You look at the baby at the level of the baby. Is the wiggle good? That is your inspection. Is it coming up to the level of the abdomen and the thigh, or is it crossing into the thigh? Are you overdoing it or are you underdoing? That's your inspection. Whereas in your palpation, with your two tips of your 2 fingers, you need to close your eyes and just have your fingers on either side of the chest. See how is it sort of expanding to your pulp of your finger. That is your palpation. At the same time, is your oxygenation coming up? At the same time, is your blood gases improving? So, and your X-ray, you should have at least 8 to 9 posterior ribs. So this is the rough thing when you get to getting this child onto the oscillator. And as I said, FiO2 as needed. Okay. So that is your oxygenation. Next, is your ventilation or your carbon dioxide removal. So if you want to either generate carbon dioxide or, you know, make it optimal up to 30, 35 or even 40, or even if you want to get rid of your carbon dioxide and, you know, you want to do that, you have a lot of things to play with. Okay, so there are a couple of things. One is you're increasing the delta P, decreasing the frequency, increasing the inspiratory time, and increasing the cuff leak of the smaller ET. Okay, next slide please. So here, this is quite important. As I said, the primary manipulations in the PaCO2 are achieved by altering the oscillatory pressure amplitude or the power. Okay, the increasing the delta P increases the displacement of the diaphragm and the piston. You can hear it much rapid sound, and then increasing the gas exchange and the tidal volume delivered, and lowering the alveolar and the arterial PaCO2. So it is adjusted on a relative scale of 0 to 100%. So usually what I do is I see the blood gas, what is there in the previous one. Let us say the blood gas, the CO2 is around 60. And usually I prefer an amplitude or delta P around 60. Okay, that is a rough ballpark. The other thing is, for example, as I said, map of 15 you have, delta P is 45% of 45 centimeters of water. The delta P is not allowed to go less than 4 centimeters of water. So at low MAP, where the delta P may go below 4, the ventilator also may reduce the delta P. So start with the delta P set at 60% or at the arterial PaCO2 level, as I've said. But here, I just want you to, just a word of caution. What I need to tell you what I would like to tell you is, a delta P of 60 on the sensor medics is very different to a delta P on the other machines. The sensor medics is extremely powerful, and a delta P of 60, it completely washes out the CO2. So be very, very careful. Be accustomed to your machine. That's what I'm trying to tell you. The same way, with using a lower delta P as well. So the arterial PaCO2 is managed by both the amplitude and frequency. And as I said, to enhance the CO2 removal, you increase the delta P, and increasing the amplitude above the 60% has little effect on the tidal volume and the PaCO2. That's what, as I've said, in the dragger machine, as I've said. So the next thing is, tidal volume increases as well as the frequency falls. And in the dragger, you have a thing called dCO2. That's the diffusion coefficient of CO2, which we actually use more in, I think Manoj is speaking next on the high frequency with volume guarantee. He's going to speak more on this. So I'll leave it for him. Next slide, please. So here, as I said, the frequency, right? So again, as I said, the PaCO2 is managed by both amplitude and frequency. So this is important here because the amplitude and frequency, let me put it crude. One, you have a coarse control and you have a fine control. If you see the olden days radio, the transistor we used to call, it has a fine adjustment and a coarse adjustment. Okay. So you have to be very, very careful, because if you make rapid changes in the frequency, that is not good for the child at all. That's not good. So what I would say, you should make very, very fine adjustments with the frequency, and you are okay to make big rapid strides in your amplitude. So be very, very careful. So first, fiddle with your amplitude. If you are exhausted, if you've exhausted your amplitude, that means on a sensor medics, let us say, you've gone to almost 40, 45 or 50. At the same time, you want to get rid, or you want to generate more carbon dioxide inside, or you want some CO2 and increase the respiratory drive. So what do? Is you try to, generate some CO2 inside. So what do? You try to change the amplitude, you bring it down to even maybe, 20, 15, 10. So when you've done that, that is the next thing to do when you want to wean is your frequency, or when you want to change. So this is your very, very fine adjustments. Okay. So here, as the CO2 escapes only during the expiratory phase, lowering the frequency allows for an increased tidal volume or a longer expiratory time and a more carbon dioxide removal. The percentage of oscillatory delta P transmitted to the proximal airways increases the frequency at which the delta P increases significantly. This is influenced by the mechanical properties of the lung. So usually, again, if it's a bigger child, if it's a much bigger child, you could start with a frequency anywhere around 8 to 10. If it's a smaller baby, you could start anywhere around 10 to 11 frequency. But more importantly, it is not just the size of the baby. It is the pathology. That is what is important. Okay. So as I've said, increasing the frequency builds up the arterial CO2, and decreasing the frequency up to 7 or 8 removes the CO2 satisfactorily. This is one. Next slide, please. Okay. So this is a little bit more in detail. I'll dwell a little bit more on this slide. The appropriate HERS is dependent on the disease being treated. This is extremely important. Okay. So this is what we need to understand, and this is the most important thing when you learn how to get onto the oscillator and how to set it up. Okay. Let us say you have a sick child on the oscillator. Okay. And you want to sort of get rid of the CO2. So obviously what you do, as I've said, you could use first amplitude, you drive it up to 40, 45, 50. And if you're not getting much of an effect, you try to drop it down. You already started up at 9 or 10. You could go down to 7 or even 6 or even 5. Drop down the frequency. So here in the sensor medics, what we need to understand is higher frequencies of 12 to 15. They're used in low compliance or like HMD and smaller babies with poorly complement lungs. They require higher frequency than more mature infants. These are the easier babies. Whereas lower frequencies of 8 to 10 hertz, they're used in presence of high resistance or early phase meconium aspiration, bad chronic lung disease or bad lungs. Okay. So here, the sicker the lung, the more difficult to ventilate, you need to use lower frequencies. As I said, not only 8 to 10, you could even go down even further. Whereas in the hybrid ventilators, they have limited capacity to achieve tidal volumes at higher frequency in the absence of spontaneous breathing. It may be necessary to use lower frequency in hybrids than previously selected on the sensor medics, as I've said. So you might end up using even 4 or 5 of frequency in these hybrid kind of ventilators. In general, the highest frequency achievable should be used to reduce the risk of barotrauma when using HFOV in the hybrid. That is important. So you need to know your machine first. So once you get used to it, it's very, very easy, but you need to know your machine first. Next slide, please. The next thing, we don't meddle with this all the time. We hardly meddle with the inspiratory time, but yes, when we have to, you certainly need to know. These two measures to change the CO2 is very, very unlikely. Yes, sometimes I've used the increase the percentage inspirated time I've done, even in the oscillator. So what you could do is, usually it is set up at 33%. So let us say you're finding it difficult to get rid of the CO2, you could gradually go up to 40 or even 50%. Okay. And as I said earlier, the ratio is 1:2. You could increase it to 1:1, inspiration expiration ratio. So that might improve the CO2 elimination. Okay. So that is in the very, very rare cases you could use that. The other thing, as I've said, is the increase in the cuff leak or the smaller endotracheal tube. This is very, very unlikely. This is used most in the adults, in ARDS, or in the pediatric population or the big pediatric population where I see. But certainly this is not used in the neonates. Okay. So this is the rough thing where I just stopped short of going into recruitment of the lung, because that is the next big topic where we have two topics of both the recruitable as well as the non-recruitable lung. So this is the thing, and thank you. Next slide, please.
Thank you very much, sir. And it's a wonderful session, and now the session is open for discussion. Dr. Prakash Femgal, sir.
Yeah. Can you unmute? Yeah, unmute.
Yes, yes. And you can start the discussion.
Yeah. Can you hear me?
Yes, sir. Yes, sir. We can hear you, sir.
Okay. Before I get all the questions, I would like to thank Rahul as well as Satish. It was fantastic. It was nice to hear you both. Rahul, I have one question and then followed by Satish later on. Rahul, can you hear me?
Yeah.
He can hear you, sir. Go ahead, sir.
I can hear.
Okay, Rahul. I have a question regarding the the scalars as well as the loop.
Yeah.
Basically, nowadays we don't use much on the bedside, and we all experience that. The reason is most of these babies don't go into conventional or any ventilation, and they are early. Even if they are ventilated, they ventilate early and they come out of ventilation quite fast. And we use CPAP nowadays.
Yeah.
So
Hello.
I think sir's internet got stuck. Hello. Dinakar, sir? Prakash,
Yes.
yeah, I can hear you.
Yeah. Please continue, sir.
So that's one question. And in
Can you repeat
preterm
the
babies,
question, sir? We could not hear in between, sir.
did you hear the question, Rahul?
No, we couldn't hear the
CPAP.
Sorry?
I heard that most of the babies are on CPAP. After that, I didn't hear.
Yeah. So nowadays, most of the babies are on CPAP. So what is the role? Like in the sense, most of our graduate students probably don't learn which are more important. Like you kind of explained in detail about the scalars as well as the loops.
Yeah.
But if a child is more than 1 or 2 days on a ventilator, probably can see the pulmonary dynamics based on the pathophysiology. So as a teacher, as a senior consultant, do you think that we should insist? That is first question. Are there any papers to suggest looking at the loops or the scalars, whether we can have a better outcome on the babies who are ventilated? Like what we have learned over the years is looking at the gases or how the clinically the baby improves, then you change the ventilator parameters. That is babies who are ventilated.
So your voice is not clear, sir.
I think sir's voice is breaking. Probably. Hello, sir. Your voice is breaking, sir. Can you repeat the last few lines, sir?
So can you hear me now?
Yes,
Yes.
sir. Yes, sir.
So the second question is when the babies are ventilated in preterm babies, they are not having cup tubes. So there's a significant leak. So how do you kind of compensate that to interpret it on your scalars as well as in loops?
Yeah. Coming to the first part, probably on CPAP, I feel still the loops can help probably to pick up air trapping, scalars and loops both, probably
Yeah.
to pick up any leak or any over distension. And coming to the second part about the studies, I'm not sure about any studies which show like better outcome when we monitor scalars or loops rather than monitoring other parameters. But what I find in clinical practice, like if we have a look at loops or scalars along with other parameters, definitely it will help us to pick up the complications earlier, and it will help us to rectify them earlier. Third part about a leak. So the possible answer is a volume guarantee, which will take care of the leak. It will take care of about 70% of the expiratory leak. And if we put this patient on volume guarantee, that will be the solution for it.
Right. Okay. Prashant, do you have any questions the audience have posted?
1 second, sir. I'm just unmuting Dr. Dinakar, sir. Sir, there are any questions from for you, sir, from Facebook and YouTube, sir? Dinakar, sir?
So,
Any questions from Facebook and YouTube, sir?
Facebook, there are 7 questions are there.
Yes, sir.
Can I ask?
Yeah, hi Dinakar, you can ask because I don't have the questions here.
Yeah. No, Facebook is there, no? Facebook questions are there. Why you not able, you should have, Prashant, why you not given to
No, that's a separate login, sir.
This is Zoom, right?
Sorry.
Zoom, sir, that's why. Carry on,
Okay.
sir. Carry on, sir.
What about Dr. Rahul?
Sir.
What about graphs when we use nebulization?
I didn't cover it. Because newborns, I mean, in my practice, at least in newborns, we hardly use in nebulization.
Well,
Yes.
you did show one of the.
So that was for a bronchodilator, say like response to the bronchodilator. That is
Yes,
also
that's a bronchospasm, right? So
but we hardly
No.
use any
Why I asked?
in newborn.
See, it is this question.
So your voice is not clear, sir.
Can you hear me now?
Yes, I can hear you.
Yeah, nebulization. This question is from my postgraduate. She told me to ask you, that is the reason I am asking. What about graphs when we give nebulization or during the nebulization? Because during the nebulization, usually we do remove the sensor, microprocessor sensor, and connect the baby till around 5 minutes or 4 minutes or 7 minutes or 10 minutes. Because the flow sensor, everybody knows here, it will have either platinum or gold small filament. There are 2 filaments will be there. That filament, one filament will have a direction of the flow. One filament will tell direction of the flow, whether it is going in or out. Another filament will be heated. So during the heat, how much time that gas is flown, during that time, how much that heat, 400-degree heat, has come down. So that one will be calculated and will be told by VT, how much tidal volume is in or how much tidal volume is out. Regarding that, everything is calculated. Pressure is calculated. Everything is calculated. On that basis, that microprocessor will send the signal for the graph. So during the nebulization, that material will come and sit on this, what is that, filament. So that is the reason during the, what is that, microprocessor nebulizer, that is called ultrasonic nebulizer, what we will get specially for a ventilator, we do keep the microprocessor flow sensor apart. Number one. So
Okay.
this question is from Punjab. Punjab, what is this? How we will know flow starvation is there, sir?
I showed all the graphs about flow starvation. So it's very,
yes, sir.
Yeah, it's very clear. So if we look at the scalars on a flow waveform, the inspiratory flow will come to the baseline and it will remain at the baseline before the expression starts. So there will be a zero flow state. On a pressure waveform, you can see there is a deepening of the inspiratory portion. Similarly, in loops, both pressure volume and flow volume loops, you will see there is a deepening of the inspiratory portion.
Yes, sir.
Yeah, I think that's pretty clear.
Yeah. So how we will know the flow starvation? Sir has told very clearly, Singh ji from Punjab, I don't know, just I am giving you the word G. So we don't know really how to, means we don't know, sorry. We heard how to know the flow starvation. So very clear. Usually what will happen in the flow starvation is, number one, in the PV loop, actually what Rahul told, figure 8 will come instead of the normal figure.
Yeah.
That figure 8 is figure 8 means it is reversal. That's it, nothing at inspiration should come this side. If it comes reverse, think that is the main thing. The flow starvation will come. Then there is one more, 2 questions are there for Rahul. Please, I'll ask for the Dr. Satish Ganta. Sir. Dr. Satish Ganta.
Yeah, I'm able to listen.
Yeah, sir, how to choose the frequency, optimal frequency? How you are going to know? Only in the books we read. If it is a small baby, keep 12 to 15.
Yeah.
If it is a late term baby, we read 10 to 12. If
Yes.
it is a bigger baby, less than 10. Sir, is there anything how to choose the frequency?
Yeah, very, very good question. Very practical, sir. Thank you so much for that question. But
No, sir. This question is not from Dr. Dinakar. This question is from your own state, Telangana.
Yeah.
Reddy, Sumant Reddy.
Yeah. No, basically it's a good question. Sir, I think the most important thing that we need to understand here is selecting the frequency. As I've said earlier, very, very important to know your machine first, number one. And very important to know how the child is. Let us say you have a sick child, very sick child. For example, let me talk about oscillator with the sensor medics. So I have sensor medics with me. So this child is a bad meconium aspiration syndrome. The saturations were sitting in the 80s and the CO2s are something in the 70s or 80s. So I get this baby onto the sort of the oscillator, the high frequency sensor medics. So what is important here is it should give me a feel. As I said, there is no single number. There is no magic number. So the magic number here is what is it that we need for this child which is needed. As we've said, let us say CO2 was only about 70 and we know it's a sick child. So let us say I have sensor medics. So I have my delta P around 60 and I've used a I've used a frequency of 8. So what I see what I'm going to look at is the baby going to improve? Is the baby going to get better with this? And is my CO2 going to come down? So what happens is, there is no magic number, as I said, whether the CO2 is going to come down with a frequency of 10 or 9 or 8. That is important. So what matters is what is the machine you have and how sick is the lung. That is important. So what I do is, let us say I have sensor medics with me. I try, if it's a sick child, I'll do something like a frequency of 7. Okay. Next thing what I do is I get a quick blood gas within half an hour and a quick chest X-ray. So a quick blood gas with a quick chest X-ray, if I'm getting a rib expansion of about 8 to 9 ribs, and more importantly, if my CO2 is coming down within the first half an hour to 40 minutes, that means I'm on the right track. If I'm not, as I said, there is no hard and fast rule that there is no, that this is what is going to work. So you have to choose. Suppose the same kind of a situation, let us say I'm having a different machine, a different oscillator. Let us say I have a, SLE or even for that matter, Draeger. It might not work. Then, you use even amplitudes or if even 70, 80, 90. What is important? You need to go down further. Go down to frequencies of 5 or even 4 or even 3. That is extremely important. So what is important is know your baby well. What is the compliance of the lung? How sick the child is. And then once that is done for the first 40 minutes, get your baby, get a quick X-ray in 40 minutes, get a quick blood gas, and then titrate your CO2 and titrate your frequency around the blood gas that you get and your pH. So, but you could see what your experience is, but this is what I feel.
Yes, sir. Sir, can I add one word with your permission?
Yes, please. Yes, please.
Sir, how to keep the frequency? It is from your state, Reddy, yes. Sumant Reddy. Yes. Sir, yes. Only one thing, Sumant Reddy, it is for you.
Yes.
Frequency, how to choose? Yes. I do the same thing what you asked the question, but the real thing is frequency we will choose without volume guarantee. HFOV I am talking, or sir is talking. If the time constant is very short, I use, because what you mean by time constant is very short means atelectatic lung or elasticity compliance is low. In that lung means alveolar problem is there. In that lung, I use because if I use high frequency, I will deliver low tidal volume. that low tidal volume will prevent the volutroma as volutroma. That is the concept we use high frequency. So that means in the low elasticity or comprehensive low lung. If the lung in between, example, like a pneumonia, like a PIE, so like that condition, we do use a middle one. Suppose if the lung is really PIE is there, means extensive PIE, in that resistance is very high as well as minimal compliance also less. During that condition, I need more volume to flow, but delta P low, so I do use low frequency. Everything is depend on frequency choice is about the time constant. That's all, sir. Sir, one more thing, sir. Dr. Ganta, sir.
Yes, sir. Please.
How much lung, sorry, or chest? It is from Tamil Nadu.
Yeah.
Akram.
Yes.
How to choose the delta P? How much to wiggle? Because each book will tell one thing.
Yeah.
What should I follow, sir? One book is, one second, wait. One book is telling it should only chest is wiggle. One book is telling umbilical should wiggle. One book is telling upper thigh should wiggle. Whether it applies to all the babies or what should I do, sir?
Yeah, no, this is another very, very good question, and this is what usually this thing, but that is extremely important here. See, what we have to understand is your clinical aspect. So how much of delta P to use? There is, again, horses for courses. That means there is no one answer for your, question. There are multiple answers. So think through whatever I have said, First, when you choose rough ballpark, you need your earlier blood gas. The best way is, let us say your earlier blood gas, the PaCO2 is around 60, 55 to 60. So rough ballpark is, I do my delta P around 55. So maybe around what the CO2 is. But that is not the thing, it is important. So one, you should know what you start with. That means the nurses are getting the baby ready. You're about to set the ventilator. So you have to have a number. So what I do is practically based on what my CO2 level is earlier, I choose my delta P. Clear? Number one. Number two, once I've done that, I've hooked the baby onto the ventilator. So I do my clinical things. Very, very important. 4 things which I use. Clinically means looking at the baby. That means inspection. Number 1. Number 2, palpation. How do you palpate? That is important. So these 2 in terms of your clinical aspects. The second thing is you look at the monitor. So whatever you're doing with whatever amplitude, are the, is the monitor getting better with what, the heart rate, is it coming down? Is the child looking better? So inspection wise, does the child look better? Is the wiggle looking better? Now, in the inspection, the wiggle. So certainly I don't want my wiggle until the thigh. No, I want it around the umbilicus. Okay, around the abdomen. I don't want it in my thigh. If your thigh is wiggling, that means you are overdoing it. So you could bring it down. Next, so your are we clear? So starting off with your carbon dioxide in your blood gas, number 1. Number 2, then going to your inspection. Looking at the child. Is the child clinically better? Pink, looking good. At the same time, your wiggle. How good is the wiggle? Same time in your inspection, when you see the baby, you should get to the level of the baby and see the wiggle. That is extremely important. And then you even palpate, as I said. You palpate how good is the wiggle. Once that is done, as I said, you need to look at the monitor, you need to look at the X-ray, and you need to look at the blood gas. So you need to, as soon as you get the child on the oscillator, within 40-45 minutes, you need to get a blood gas. At the same time, you need to get a chest X-ray done. So based on these things, at the end of 40-45 minutes, having started at the CO2 level, looking for the whole, wiggle and the whole thing, I wait for 45 minutes. And once I finished my wait, I get my blood gas and my chest X-ray. Depending on that, If the child is, the blood gas is much, much better, I would even think about reducing the amplitude, or if it's bad, I don't mind, consider going up. So very good question. It's a practical question. What is important is you need to sit with the baby. Okay. Many a times the residents keep asking me, sir, I put the baby on the oscillator. Can I go elsewhere? No, you have to sit with the baby. As soon as you put this child on the oscillator, as soon as you get the blood gas, so the first 40-45 minutes, your recruitment needs to happen. So once you put the child on the ventilator, you recruit your lung well by all the recruitment maneuvers. And when you get your blood gas at the end of 45 minutes, that is when you see, yes, I'm on the right track. If it's not good, you need to change it, get the next blood gas. And only when it is well recruited and you have an amplitude which is sort of reasonable and a delta P or a frequency which is reasonable, then is the only time you need to step out of the room, not otherwise. I hope I've answered your question.
Yes, sir. Sir, one more thing. How to know the optimum MAP and COPCC? Critical closing pressure, I think so. Critical opening pressure.
Yeah.
How to Siddharth from MP?
Yes. See, basically, this question is about recruitment of the lung. See, what I've just said is first, your MAP. How do you choose? Again, first you should know what your MAP is on the conventional ventilation. If your MAP on the conventional ventilation is 18 or 19, you choose at least 2 or 3 above the conventional ventilation. That is only to start. That is only to start. But when you do the start, the next 45 minutes or 1 hour, it is all about recruiting the lung. Okay. And as you rightly said, critical opening pressure or the critical closing pressure, it's not in the textbook. What many people have heard is, I'm speaking to some of, very, the students who come, sir, high frequency is fantastic. It is very, very advantageous. You directly oscillate this child on the deflation limb. No, sorry, boss, it doesn't work that way. It doesn't work that way. Just because you're on the oscillator, that doesn't mean to say that you've nicely recruited and you're sitting on the deflation limb of the pressure volume loop. No, it doesn't work. So what? You have to get it there. You have to get there. So to get there, you should know, using various recruitment maneuvers, you should know what is the critical opening pressure. You need to know what is the critical closing pressure. So once you recruit your lung, that means, you keep going up on your map, So here, you know that you're good. And when you've really opened up and completely sort of past that area, where it is the critical opening. And when you start coming down, that is when you start bringing down your mean airway pressure. And when you start desaturating, that is when you go up above on your critical opening pressure, 2 above that. And that is your sweet spot. See, there's one whole 30 minutes is dedicated for a recruitment. And, you should sort of visit that lecture as well. But what is important, the take-home message for you is, there is no number on the textbook. There is no number on the, on any of the internet. No, you have to fix that number. You have to exactly find out what that number is. So how to find out, how to know what is the critical, opening pressure? How do you know the critical closing pressure? That is all about recruitment. So that is what I'm saying. For the first 1 hour, all you need to do is get the baby on the vent, recruit the lung, know what the critical opening pressure, know what the critical closing pressure is, then get the baby onto the deflation limb of the pressure volume leap, and that is where so you don't get a number straight away. I hope it is a very long topic, but I hope I've answered your question.
Yeah, sir, critical opening pressure or critical closing pressure, everybody knows it.
Yes.
So Dr. Siddharth, I think so you understood from MP. You understood what sir is told is very clear, but only one word you have to remember. What is the difference between conventional ventilator from HFOV, Dr. Siddharth. Only thing is there PEP we do use. Here MAP is there because in CMV also MAP is there. The same thing what we will do, we are expanding the lung, Dr. Siddharth, just above the FRC. FRC means functional residual capacity. That means both things are there, residual capacity and expiratory volume. Just above that, we are expanding the lung, not at the FRC. Just above the FRC, we are expanding. So if you will expand like a balloon little less, it will be like it will be there only, like an old. If you a little more bulge it might go in the air. If it more bulges, it is more dangerous. So that's what critical opening pressure. You will know slowly when you will be accustomed to that. So Dr. Wasat, there are so many questions. Another, now it's leaking. I mean, it's leaking. Our great Dr. Rahul, Haji, it is from Maharashtra, your own place, boss. Sohale, Sule, somebody. What you mean by, sir, air leak and air trap? Do you think air leak means, is it a pneumothorax? Air trap means, is it a pneumothorax or something else? Because in both, air is not coming to the flow sensor. How you are going to tell about the graph, sir?
Yeah, I mean, I don't know who has asked this question, but if you have seen the slides were self-explanatory. Obviously, whenever there's a trap, so it is because of say like you can in air trapping and air leak, both pressure volume and flow volume loops they'll look different. Though it won't reach baseline in air trapping, it will expiratory portion will come to the volume volume axis. It won't come to the FRC, but it will come to the volume axis. Whereas in leak, it won't come to the volume axis, and that is how you make out leak and trapping in PV loop. Whereas in flow volume loop, you will see like the expiratory portion will come to the flow loop, say flow axis, but it won't come to the FRC in case of air trapping. Whereas in air leak, the expiratory portion will come back to the volume axis, that is x-axis, but it won't reach FRC. So you can differentiate based on loops, both FE and PV loop, trapping and leak. And yeah, I think.
Yes, sir. Dr. Sohale from Shole, from Maharashtra, I think so. Simple thing what our Dr. Rahul has told is very, very clear. If there is an air leak, remember in a different tone, dear friend, leak means early. It is before it won't come in the PV loop or flow volume loop. It should come and meet the same place. So if it is leaked, that means it is not coming. It is somewhere so early leak. Arey yaar, thoda samajh lo. Okay, then air trapped, thoda zyada badh gaya. So it is also not coming to the point. It is going beyond the point. So air trap. So try to understand. This is the only way to remember, because my teacher taught me that is 12 years back. Air leak means it is not coming early. It is coming and contacting that X line. So trap means it is going towards the Y line. That's, if you'll remember, that is enough in both the things. Sir, one more thing for you, sir. Ganta, sir?
Yes, sir.
Okay, sorry to disturb you, sir. There are two more questions. Do you think
please.
Open section or closed section, which is better in the HFO, sir? UP from Chowdhury.
Yeah. See, if money is not a problem, if money is not a problem, I think closed suction is any time better. Not only for two things in terms of ventilation, in terms of infection. If you see right now in the COVID season, all of us ventilating children are shit scared. You know, why are we scared? Because they say, don't use the nebulizer. Be very, very careful while ventilating. Very, very careful while doing suctioning. Why? Because there is a spread of viruses. Not only viruses, could be any microbes. So bottom line is, it is very, very dangerous in terms of infection. Preventing infection, closed loop suction is best, no doubt about that. Number one. Number two, if you have that again, if you have a closed loop suction, which is a little bit more expensive, what happens? You don't even lose the pressure. You don't de-recruit the lung. So what if you see, normally when we want to do suction, what does the nurse do? The nurse opens it, does a good suction. Some people have a habit of putting a little bit of saline and then do every time you suction. What happens? You are losing at least 20-30 seconds of time. 20-30 seconds of time. This child is not ventilated, even though you bag in between. It is not optimal. At the same time, you're trying to use negative pressure. So you're de-recruiting the lung. De-recruiting the lung. So if money is not an option, I would stick my neck out and say the standard of care is only and only closed suction.
So Chaudhary sir, समझ गया शायद. I think so. It is a closed suction, sir. Better. Sir, one more thing. Do you think some journals, sir, Satish Ganta sir,
yes,
it's for you. Do you think some journals tell, I have read, some journals tell decrease the frequency 1, 2, 3. Accordingly, CO2 will reduce 4, 5 to something. Do you think I should follow this, or is there anything I should follow during the frequency? Because some journals are telling. Do you agree?
Yes.
It is from, I think so, Delhi, sir.
Yeah, this is a very, very practical thing. But see, I don't think you should put too much emphasis on many ways. What you should understand is there are many different ways of doing the same good and right thing. That is important. Okay. There is no set pattern. Everybody is used to a certain pattern. I would tell you what I'd be doing. Okay. So when we have a child who is sick, what did I say? Certainly we will use higher amplitude and a much lower frequency. And when the child is getting better, usually I don't meddle with the frequency at all. Let us say I have a sick child on a amplitude of 60 with a delta P of, let us say, only 5 or 6. So when this child, let us say with meconium aspiration syndrome, is getting better, my aim is I want to get my amplitude, which is at 60 or 70, down to the 20s and 30s. So when I have my amplitude down to 20 and 30, and my CO2 at admission, let us say it was in the 60s and 70s, my pH was 7.2s and 7.1. If it is getting better and my amplitude is down, that is the only time I touch my frequency. And as I said earlier, frequency is fine tuning. You know, you could use not more than one. Whatever your frequency, see, in the sensor medics you have, 3, 3.5, 4, 4.5, gradually you go up that way, isn't it? So once your CO2 is really getting washed out, after your amplitude is down to the 20s, that is when you slowly start increasing your frequency, depending on what is the value of your CO2. If it is really low, yes, you can do in quick successions from your amplitude, of your frequency, from your, 5 to 6 to 7. So I usually go up to even 12 or even 14 before I extubate. So what my advice to you, doctor, is don't go by what the book says. Just go practically. Look at the child and see. The basic principle is a sicker child will need a higher amplitude and a lower frequency. And once the child is getting better, the child will need a much lower amplitude and a higher frequency. So get down the amplitude first and then slowly increase the frequency to 10, 12 and even 14. So once you are in around 12 or 13 or 14, your child is ready to be extubated. So that is more important than rather trying to follow a principle or a tabular algorithm or something like that. Okay.
Sir, very good, sir. I think so, sir has understood. There is nothing like frequency decrease and CO2. It is all in CMB ventilators. It is there because almost CMB ventilators were driven, because here it is all frequencies and whatever you tell, it is only as Sir Ganta sir has told, it is depending on the horse and the power. So you cannot tell that. So in the HFE, it is only the power of the machine. So please, sir, don't go with whatever you read the articles, or it is all Australian. They all tell, and it is a team. I mean, Sensor Medics 300. Even I read it is in 2000s. So please, sir, don't go with the articles, because you have to go with. Don't go with the numbers also. You believe yourself, and you believe your machine how much it is power. Even delta P, what Satish Ganta told is very clear. That is only depend on power, because if you will use the dragger 8000, it is not at all having the power. You might need delta P 1000. If you will use the other ventilator 60, 80. But to tell you very frankly, I never use more than 35 to 40 in my life, even with a stone lung. What I am telling, very hard lung. Sir, one more thing. Satish Ganta sir, in Sensor Medics 33% is there, where I took my fellowship. But now I am buying, what is that, Fabiana machine. In that Fabian machine, in that 1:1, 1:2, 1:3 is there. Sir, what do you mean when to use this 1:2, 1:3, 1:1, sir?
Yeah, very, very good question.
This is from once again Delhi, sir, Dr. Lalan.
Yeah, Dr. Lalan. It's a very, very valid question. The Fabian has it. See, as I've said, we need to be more close to physiology. What is physiology? Inspiration to expiration is 1:2. That is the usual thing, right? But in case you have a very sick child where you're struggling to get your CO2 out, that means you used your amplitude maximum to 40, 50, even in the other machines you have even 60 to 80. You use that, you come down on your frequency to as low as 4 or 5 or even 3. But despite that, let us say your CO2 is still high. In those kind of scenarios, this would be useful where in your 33%, that means in your Sensor Medics, they say 33%. So that means 33% inspiration and expiration time is obviously 67%, right? So that 1:2 ratio is changed, let us say, to 50%. That 33 it has come to 50. That means inspiration to expiration is equal. That means you are driving the lung more. Okay. So that means earlier instead of 1:2, what is physiology? It says 1:2. Now you want to do 1:1 ventilation. So 1:1, that is IE ratio, 1:1, or sometimes we use inverse also. This case is that means it's a very bad lung. Your back is against the wall. You don't have a choice. And only that time, whether it is Sensor Medics or Fabian, you increase your I time from 33% to 50%, or indirectly, you're increasing your IE ratio from 1:2, you're increasing it to 1:1. So that is a very bad scenarios. You could use that, but otherwise, usually oscillation, it is fixed at 33% or 1:2. Okay.
Yeah, sir. This is the last question to Dr. Our Rahul. Rahul, are you ready to take?
Yes.
So, sir, the question is very lengthy, boss. Please listen to me carefully. Dr. Prashant, are you there? Dr. Prashant.
Sir, bolo.
Okay. Dr. Prakash Vengal.
Yeah, I am there, Dinkar.
Okay.
I am there,
This is the last question, sir. Yeah, sir, I am your fan. Rahul ji, आपके लिए. Tell me what should, sir, I am your fan. Tell me what should I see practically in graphs, and when I read in books of graphs, and when I attend PPTs of the graphs, I understand better. And the illustration is super. But when I go and stand in front of ventilator, it is alien language or it is Hebrew language. Sir, please help me. And 2-3 namaskaras are there. 2-3 namaskaras.
Okay, answer to this question is last slide of my presentation. So it's experience. I mean, we need to be there and experience it several times to understand.
I think Rahul, he needs to be trained under you. That's on a lighter note. I think most of these graphics in a clinical application, you need to stand next to the ventilation, learn, and it has to be a continuous process. You can't stop after a couple of months or years, because then you tend to forget. It's like reading a ECG. So that is what I would like to probably say a few words.
And other things, sir, what I feel is just not looking at the graphics. You need to look the clinical presentation of the TB, what you are suspecting, and then you look at the graphs. That may help.
Yes.
So you should know which graph to look for.
Yeah.
Yeah. So I think so. He is your fan. He has written that also bold and big capital letter. Anyhow, all the best, Rahul ji and Satish Ganta sir. He is your fan, yaar. He has written, "Main kya karu, yaar." Okay. And very happy, Satish Ganta sir.
Yes.
No, good at least. Satish Ganta sir, thank you very much for your class, sir. Very nice, excellent. I don't want to talk simply. As usual, you were awesome. And Rahul तो बोलना नहीं चाहता. Very अरे यार वो बहुत दीवानी हो गया fan गिन. Okay, over to moderator sir.
Thank you.
Yes, boss.
So, do you have
Prakash Vemgal, it's for you.
Yeah. So I would like to thank once again Rahul as well as Ganta sir. Probably it's been a refreshing course for me too. We do keep doing things on the bedside, but when we hear from you guys, it makes us a little bit more cautious about what we do.
Yeah, Prashant, tomorrow class, please, can you?
Yes, sir.
Sorry. So I would like to thank once again the NNF Karnataka chapter for just allowing me to moderate this session. And over to you, Prashant.
Thank you very much, sir. So we have the next class, that is day after tomorrow, on HFOV application in recruiting lung and HFOV application in non-recruiting lung by Dr. Ramarao and Sheshagiri. So I request all the participants to take maximum advantage. Please share this with your friends. Already sent the link in chat. Please copy paste it. Sir, it's indeed a wonderful presentation by both the speakers. A special thanks from NNF Karnataka entire office. Thank you, Dr. Satish sir. Thank you, Dr. Rahul. Thank you, Dr. Prakash sir. We'll catch up again after tomorrow. Thank you.
Thank you so much. It's been a pleasure. Thank you so much.
Thank you, sir. Thank you.
Thank you, Dr. Delagar. Everybody.
Thank you, sir. Thank you.
Thank you again.
Have a good day. Have a good day.
Bye-bye.
Bye-bye.